move on to our second presentation from Medicine 2 by Dr. Lino.
Good morning, everyone. I'm presenting on behalf of Medicine 2. Today, I'm going to share a clinical finding which I learned over the last few weeks. So, this is Mr. Y, 36 years old driver from Jharkhand, presented with recurrent fever episodes for last 7 months. He has a low-grade intermittent fever with chills and predominantly evening rise of temperature that subsides with medication and reoccurs. For this, he was evaluated outside multiple times, but there was no diagnosis was made. Along with the fever, he also had a cough for 7 months. The cough is whitish with mucus expectoration. However, there is no seasonal or diurnal variation associated with the cough. There is no history of hemoptysis or shortness of breath. He also noted swelling of face for the last 1 month. He noted swelling over the face which worsened in the morning and then improved slightly as the day progressed when he was upright. There is also associated history of loss of weight for almost 10 kgs over 6 months associated with loss of appetite. There is no history of TB contact. There is no history of joint pain, oral ulcers, alopecia. At presentation, examination showed he was conscious and oriented. He was hemodynamically stable with a pulse rate of 92 per minute, BP was 130/70, respiratory rate was 18, and he was afebrile at time of admission. Some positive examination findings were there noted prominent dilated veins at both the sides of the neck. However, the Pemberton sign was negative at presentation. Other system examination was normal. So this is the patient's photo that one is showing after in the early morning picture that shows bilateral prominent dilated veins in both the sides of the neck with plethora and swelling. And as the day progresses, swelling decreases and venous distension also goes down. So what is a diagnosis? What is the syndrome? SVC syndrome. So this is a gentleman, 36 years old, with prolonged fever, non-productive cough, with a significant loss of weight and SVC syndrome. What are the possibilities? Can be both a malignant and non-malignant etiology. However, in our patient, there is a history of significant loss of weight, loss of appetite. The most likely differential consider is secondary to malignant etiologies, like it can be secondary to lung malignancies like non-small cell carcinoma of lung, small cell carcinoma lung, lymphoma, metastatic cancers, or germ cell tumors, thymoma and mesothelioma, and other. With this evaluation, I will just touch what are the grading of SVC syndrome. If patient is completely asymptomatic and the only imaging suggestive of SVC, it's a grade 0, and if there is only edema of the head and neck, it is grade 1, and if there is edema with functional impairment, then it's grade 2, moderate, and if there is features of cerebral edema or laryngeal edema, then it is severe. If it is life-threatening, like significant cerebral edema, laryngeal edema, or hemodynamic compromise, it is 4, and in case of death, it is 5. So our patient's basic investigation showed normal counts, normal hemoglobin, calcium, phosphorus, uric acid, potassium was normal, liver function parameters are also normal. This is our patient chest X-ray that showed a mediastinal widening with probable mediastinal mass. So when you see a patient with a mediastinal mass, what are the basic differential we includes based on the compartment which the tumor belongs? If it is an anterior compartment, can be a thymoma, a thymic mass, or a lymphoma, or a germ cell tumor, or even a thyroid carcinoma with intrathoracic extension is possible. Lipoma, liposarcoma, fibroma is other possible. If it is involving middle compartment, can be a bronchogenic cyst, lymphadenopathy that is causing obstructive symptoms, or esophageal tumors. Or when it comes to posterior part, this could be neurogenic tumors or spine lesions. So whenever you see basically patient with a mediastinal mass, so we go step by step. As any other tumor, we get a proper clinical history and physical examination to look for any other distant lesion. And age and sex is also paramount important because certain malignancies and certain tumors are pretty related to sex and age. And based on the progression of the tumor, it could be a slow growing or a fast growing. In the case of slow growing, one example is thymoma, and if it is rapid expansion, it could be lymphoma. So in addition to that, again, detailed history and detailed clinical examination to look for distant size, not only tumor confined to mediastinum, is there any other secondaries located in other area? So after this initial approach, we should always keep in mind tumor markers, because mediastinal tumors are one that feasibility of biopsy and biopsying the tumor is always of great difficulty. Tumor markers helps a very important role in that. The tumor markers like alpha fetoprotein and beta HCG, lactate dehydrogenase, and anti-acetylcholine receptor antibodies that's seen in myasthenia gravis. So as soon as we see after seeing suspecting mediastinal mass with reasonable good clinical examination and history, then we should think of ordering a tumor markers. In addition, then followed by that imaging and feasibility of biopsy. So in our patient, we had he showed a alpha fetoprotein of 3028, beta HCG of 140 elevated, and the LDH of 762. So most likely possibility of germ cell tumor is what we considered. One speciality of germ cell tumor is germ cell tumor has almost 90% survival rate at the end of 5 years, and even we can start treatment without biopsy. So however, we proceeded with a CT neck thorax that showed a large lobulated heterogeneous enhancing mass in the anterior mediastinum that is enhancing the bronchi with mediastinal and supraclavicular adenopathy. We have put up a consult to medical oncology, and medical oncology took over the patient. Currently, the patient is on cystatin plate-based chemotherapy. However, they have done a FNSC also to confirm a diagnosis that also showed a germ cell tumor with seminoma test component.
Thank you, Lino. Are there any questions to Lino? Was there some skin changes that you said? No, no skin changes, just facial swelling.
Yes, ma'am.
No questions? There are no questions on the chat box also. So why did you call it Pemberton's?
Just curiosity, just to make curious.
So what is Pemberton's?
Ma'am, same like superior vena cava syndrome that helps to find out a thoracic outlet obstruction. Like when we have to make rise of the hand of the patient touching the both the side of the head for almost a minute. Post that, patient may develop plethora, congestion, breathlessness.
So where did Pemberton describe it?
Thyroid.
So that was a little more, Pemberton's is more specific for a thoracic inlet obstruction. SVC can be a little more deeper, like you're saying, a mediastinal mass. So it's a bit different, but the concept is the same. It's the venous congestion which is giving rise to the patient's symptoms. Thank you very much, Lino. Thank you for the pictures.
Thank you.
We appreciate it. Thank you.